Thank you. Well, that was wonderful. That will be a new required talk for lab trainees to listen to if you haven't written a paper in the future. Okay, great. So now we're going to transition into the last part of our lab meeting, hearing about some data. So Andrea and Hannah, we have both of them here who have worked on data from the perinatal buprenorphine database, focused on our incarcerated population and looking at opioid use disorder treatment outcomes during pregnancy. This is an area that is so under-researched for many reasons that exist that this population can't really be represented in research. And so they're not represented in the evidence that informs our clinical care. And so taking any step to fill that huge gap in knowledge is a form of advocacy, in my opinion, for this neglected patient population that, just doesn't have a lot of agency when they're incarcerated, and even when they're no longer incarcerated. You put that in pregnancy together and it's quite challenging. So I'm excited for us to start filling that gap in knowledge with our own data, and I will let y'all take over.
Let me see if I can share my screen.
I can introduce myself while you're getting that set up.
Okay, sure.
Also, thank you for sharing. I really can't work Zoom, so I appreciate it, even as a young person. So I'm Hannah Shadowin. I'm a MD PhD student. I'm in my 4th year out of 8, so halfway done. Done 2 years of medical school and 2 years of my PhD. I'm in my 2nd year of my PhD. I'm getting my PhD in healthcare policy and research, and I focus mostly on Medicaid and my own work and social determinants of health. But I have joined forces with Dr. Martin, and it's been wonderful.
I'm Andrea. I am a 4th year medical student and working with Hannah on this. All right, so our study is titled Impact of Incarceration Status at the Start of Medication Treatment for Opioid Use Disorder, which I will refer to as OUD, on continuation of MAT, which is medication-assisted treatment at delivery among pregnant women with opioid use disorder. So brief intro about OUD and incarceration. It's a leading cause of pregnancy-associated deaths, as I'm sure many of you know. And just a little background, there are 3 usually main treatments in terms of medications that we give patients with OUD. One of them is buprenorphine. One of them is buprenorphine naloxone, which tries to prevent overdoses. And the other is methadone. So buprenorphine and buprenorphine naloxone can be prescribed by a provider, but methadone, you have to go to a methadone clinic. And so patients often have to come in every single day to get a methadone treatment. And depending on your genetic makeup, patient's preference, whatever, they will prefer one or the other, or none at all. Studies have found that using medications reduces the risks and also improves outcomes both during pregnancy and postpartum being 1 year after delivery. And then a recent study by Dr. Suffren came out saying that about 1/3 of those incarcerated within their database were either withdrawn or not offered OUD treatment. So what this means is that when they came to jail, the jails either denied them treatment, denied them their buprenorphine or methadone, or didn't even offer it to them at all. And so what they had to go through was just a complete cold turkey stop withdrawal while they're in their cells in jail. And so you have these patients who are pretty much just like lying in their own vomit and just withdrawing with these terrible, terrible symptoms when they could be given medication. And then when they get released, that just gives them a higher risk of potentially relapsing and overdosing. And then this is the SAMHSA tip 63 that basically says OUD medications are safe and effective when prescribed and taken appropriately. And so therefore they should be prescribed to those who are incarcerated regardless. Background of what we do, most of you all know this. We have the Motivate Clinic here at the Jackson Center in the Jackson Ward, where we give medication-assisted therapy, and we also provide behavioral therapy in the form of individual and group. We also have social services, and then we have providers go to the jails and see see a lot of our incarcerated population there. And then we also have some come from the facility to VCU, to our clinics. So specifically with our study, we are comparing rates of buprenorphine continuation at delivery by incarceration status among a cohort of pregnant people. So we have wonderful database of about 240 patients, and we looked at those who were incarcerated and whether or not they had continued on buprenorphine treatment at delivery.
Awesome. So this is essentially our research question and hypothesis, the question being, how does being incarcerated when initiating buprenorphine treatment impact continuation at delivery among individuals who are pregnant with OUD? So, and we hypothesize, to be fair, this is not my expertise, this is my hypothesis. From the outset, those who are incarcerated will have lower rates of buprenorphine continuation at delivery compared to those who were not incarcerated when they started buprenorphine treatment. I don't think I can go to the next slide. Okay, thanks. So our work builds on previous work that's been done at the lab. So this is work by Dr. Martin and Dr. Shadowin, not myself, my sister, not a doctor yet. And so they looked at buprenorphine dosing among a cohort of patients who received care at VCU with opioid use disorder. And this was foundational not only to our knowledge about this issue, but also to identifying what patients were enrolled in our study. So it was really important for kind of defining the inclusion criteria within our own work. Which leads me to my next point of who we're studying. So essentially, the lab created a registry of individuals, and this registry consists of all women on buprenorphine for opioid use disorder who engaged in care with VCU health system at least once from January 1st, 2017 to March 30th, 2020, either during pregnancy or 12 months postpartum. And this was queried from the electronic medical records. And they didn't have to have all of their care at VCU. They just had to have at least one encounter at VCU. And then once the individual was enrolled in the registry, a chart review was conducted every 4 weeks for that individual until they were not on buprenorphine for at least 8 weeks, so 2 observation periods, or they were 52 weeks postpartum. So if they continued to be on buprenorphine, you're good.
Sorry.
You're good. So if they were on buprenorphine for the full 52 weeks postpartum, so the year, then they remained, they got a look back period for each of those weeks. But if they stopped buprenorphine, then we stopped doing the chart reviews. And the information about buprenorphine was supplemented by the prescription monitoring program. And that's just because they could be getting their buprenorphine from a different health system. And so we didn't want to miss that source of data. So like I said, this registry included individuals who were not included in our specific study. So like I said earlier, we were interested in looking at patients who were started on buprenorphine at VCU during pregnancy. So it was a very specific part of the registry. So I'm just going to kind of walk through how we ended up with our sample for this study specifically. So this was already mentioned, but there was 233 individuals in the registry. And remember, they could be postpartum or pregnant to be enrolled in this registry, either one. And then we wanted to limit it to just individuals who had at least 2 chart reviews conducted. So people that, had some duration of treatment. So that created a sample of 194 individuals. And then we were interested in individuals who were pregnant, so that limited it to 192 individuals. And then we wanted to look at individuals who started on buprenorphine, not just continued on buprenorphine, so that limited it to 152 patients. And then we further wanted to look at people who started buprenorphine inpatient at VCU specifically. So that was 100 patients. So that means that we started out with 100, and then our outcome occurred not during pregnancy, but at delivery. So to be included in our sample, we had to make sure that they were still in the sample at their delivery. So you can see here that 13 people discontinued their buprenorphine treatment before delivery, which means that they were no longer getting those look back periods, so they were not included in our sample. And then from the 87, we had 87 who fit all the initial criteria and also remained in the study until delivery. And of those 87, 76 individuals delivered at VCU as well. And then 11 delivered outside of VCU. And obviously, because we're looking at health record data, if they're delivering outside of VCU, we don't have access to their medical records generally. So we excluded those individuals from the sample because our outcome was specific to delivery, and we didn't have great data for those 11 who delivered outside of VCU. And so those were excluded, and we were left with the 76 individuals who fit all the criteria at that initial registration time period, and then also delivered within the VCU health system, which is why they get the lightning bolt. Okay, so then what are we interested in? So our independent variable was incarceration status. And this was specifically when they were started on buprenorphine, which is the same time that they entered the registry. So this was made into a binary variable. Yes, they were incarcerated, or no, they were not incarcerated. And then the outcome we were interested in was buprenorphine continuation at delivery. And this was a binary as well, a yes or a no. And then the covariates we also looked at were race, age, education status, and an insurance status. And we also looked at incarceration status at delivery. So obviously people can move in and out of incarceration, particularly in this population. So it's important to kind of look at how that is happening over time as well. So this is just for all the stats people, but it was really simple bivariate statistics with chi-squared tests. Like I said, our population was small, so we didn't do any regressions or anything too fancy. And like I said, we had 13 individuals who started in our sample or were included, but then dropped out of treatment before delivery. So they weren't included in our sample. There were 13 of those individuals. And then there was 11 who stayed in treatment until delivery, but didn't deliver at VCU. And then we have our sample, obviously. And it's important in these kinds of studies to look at how do these demographic variables differ between these three groups? Are they similar, or are the people dropping out totally different than the people who are remaining in our sample? And the good news is, I mean, it's a small sample, but there was no really significant differences. So that is encouraging to us that actually dropping out was pretty similar to those who remained. And so what we found is that those, the majority of individuals were 25 to 30 in our sample. So 53% were 25 to 30. This, it was also the majority for all the other groups. And then the education, it was marginally significantly different between the groups. The p-value was 0.053, so you could consider that significant, but not strongly. And interestingly, this was a really a lot of unreported or not reported data, which makes sense because we're looking at health records, but it does limit the utility of that variable, obviously. But the majority of individuals had a high school degree or less. So 45% of our sample had a high school degree or less, 12% had college degree. And then as far as our race variable, they were very similar between these three groups, the majority of our sample was white, and that was 73.3% of the sample were white. And then we looked at insurance status, and once again, very similar between these three groups. The majority were on Medicaid, which warmed my heart as a Medicaid researcher. And the next highest was having no insurance. And then this is the outcome. So incarceration at the time of buprenorphine initiation. And this is kind of the most encouraging thing to look at as far as the sample versus those who dropped out, and they were pretty similar. So 38% of the sample was not incarcerated at buprenorphine initiation, and 61.8% were incarcerated at the time of buprenorphine initiation. And that's similar to those who dropped out of treatment and those who stayed in treatment but delivered elsewhere. And then this is the headline result. We found that there was a significant difference between those who were incarcerated at buprenorphine initiation, but those who were incarcerated actually had a higher buprenorphine continuation rate at delivery than those who were not incarcerated at buprenorphine initiation. So, and overall, the rates are really high. So 79% of people who were not incarcerated at the buprenorphine initiation remained on buprenorphine at delivery, and then 96% of individuals who were incarcerated at buprenorphine initiation continued to be on buprenorphine at delivery. So that's super encouraging that people are able to stay on buprenorphine during this really, stressful time in their life. That's pregnancy, it's delivery. So it's really awesome to see that so many people are remaining in treatment, and that actually incarceration might kind of serve as a stabilizing factor in some ways, that people are able to stay in treatment if they are started in treatment. And then I just got a little curious, so I poked around and looked at how incarceration at buprenorphine initiation, how people moved in and out of incarceration, and those who started buprenorphine while incarcerated largely remained incarcerated at delivery. So 93% were, started incarcerated, remained incarcerated, but a lot of people moved from not being incarcerated to being incarcerated at delivery. So 41% of individuals who were not incarcerated at buprenorphine initiation actually became incarcerated and had their delivery during that time of incarceration. So that's pretty crazy that that's that much movement in and out of incarceration during this time of pregnancy and delivery. And then that kind of led us to question, well, how does that impact how does moving in and out of incarceration impact buprenorphine continuation at delivery? So it was too small of a sample size to do much statistical testing, but I just wanted to look at the rates of buprenorphine continuation. So for individuals who stayed not incarcerated throughout pregnancy and delivery, 81% continued buprenorphine at delivery. And those who were incarcerated at baseline and at delivery, 100% of them stayed on buprenorphine at delivery. So there was actually a higher rate of continuation for those incarcerated during this whole period. And then there was a lower amount, or actually, so the 89% of individuals who were incarcerated at baseline but not incarcerated at delivery remained on buprenorphine at delivery. So just some things to think about as we move forward in this analysis. And I'm also someone that finds lots of limitations, like our previous speaker talked about, but these are kind of the main things that we can think about and work to address in our data. The first one being that we have people that we lose to follow up. So like I said, our look back periods ended for individuals who stopped treatment. So we don't know if they went back to treatment or kind of what happened at their delivery. They're lost. And that can lead us to, because they're not included in our analysis, we can underestimate or we can overestimate the buprenorphine continuation rate because we're losing the people that stop prior to delivery. The second major limitation is that we're using EHR data, which is an incredible resource and really provides a ton of detail to patients, but it is limited to healthcare that's done at BCU. And so any care that's done outside of that, we won't necessarily see. And then the other thing is just a small data set, which we can't do much about. But like Dr. Martin recognized, this is truly like a population that doesn't get talked about or get addressed. So having data is a really important step for advocacy and providing adequate care.
So our conclusion is that we found that bupe continuation rates at delivery were high, both for patients who were incarcerated at the time of initiation and also for those who are not. And future studies should evaluate models of induction and how incarceration status impacts the OUD treatment trajectory throughout. Questions and considerations we have: what other barriers may incarcerated pregnant people with OUD face? Any future directions that you think we should take, especially since our study mainly looked at bupe continuation and then just the time point at delivery, and any other studies that can be done. So these are just some questions to kind of jumpstart your thinking. Feel free to chime in with any feedback or other questions.
Thank you, Hannah and Andrea. So happy that this project is moving along. So I have lots of things, but I get to see them on a regular basis. So I would love to hear anything from the group, anything that was a little confusing, clarifying questions, ideas for how to make the study stronger. As you can tell, this is the preliminary data. This is what we have so far, but we're super open to feedback for the data presentation itself, as well as kind of the take-home points.
I had a question. Good, very good presentation, both of you. One thought that I had is that a reason that incarceration may, as you suggested, Hannah, kind of foster treatment retention in my head is that people are away from the places, people and things that encourage use, and they're giving their medications in a monitored setting. So I was wondering if you guys would consider or did consider including status in a like supervised housing or halfway house or like intensive inpatient or outpatient program as just sort of a control against the incarceration status, since it offers kind of this similar like isolating but kind of in a good way protective factor for these participants.
Yeah, that's a really good point. And we did, we had in our chart review choices as to whether every patient was either in a residential or an intensive outpatient treatment facility. But Hannah, correct me if I'm wrong, I don't think our sample size of those patients was very high.
Yeah, I want to say it was less than 10, but I can't remember exactly. So yeah, I think that would be a great comparison group, but I don't know how usable it is based on just the numbers.
Any other thoughts people had? I know I had one clarifying question and I should know the answer to this, so I apologize. Can you remind me why that 13 people who stopped the bupe treatment ahead of, and they're not included in the sample? Can you, and I love how you showed us the demographics by that, Hannah and Andrea, but can you remind me why we did not include those in our sample if those are people that did deliver at VCU?
We don't have their delivery information because we stopped doing a chart review after the 8 weeks. So they're generally individuals who were pregnant. They were all pregnant, and then that didn't make it to delivery. So we don't have any data on their delivery.
Okay. I'm thinking Andrea's going to kill me, and we can talk about this more later offline. I think it might be worth getting their delivery data, which is very easy to do. Speaking as a person who doesn't do it. Yeah. I think, and we can talk more later about what to do for the database in general with delivery data. But I think since delivery is such a common time point that we use for outcomes, I think, Andrea, it might be good if you can get with your team and see how many patients are in the database that we did not get delivery data for because, again, they dropped out of treatment, which totally makes sense with what we said before. We just didn't think about this before, right? Until now we're looking at an outcome at delivery. I've been so focused on postpartum because that's my jam. And then maybe seeing in general how many people in the database are missing delivery data because of that, because they stopped treatment ahead of time. And then just to see what we're going to do to fix that. And then, but let's just go ahead and get that. If that's the only reason that you guys are saying we don't have them, then I think we should include them, get the delivery data, include them.
Okay, so get the delivery data for those who delivered at VCU, but who we stopped, those 13.
Those 13, yeah. Because that's something we can get. It's not like a study that you do with like real people and they're gone. You're like, oh, shoot, now I can't talk to them again.
Assuming the only hang up would be if they end up not delivering at VCU, because then we wouldn't have their data.
Of course, but then they would be excluded just for the sole purpose of that. Then we wouldn't have to include in the flow chart, right? People excluded because they didn't have something that could really affect our outcome, right? From
I think
bias.
I think it's a more accurate representation of discontinuation.
Yeah. So sorry, Andrea, I know you were like done with all the chart abstracting, but I think this 13 people is worth it. And then looking to see how many people other than the 13 exist.
Okay, yeah, I mean, it's fine. If it's just their delivery stuff that I'm looking at, it's just like one time point, yeah, in their chart.
Yeah. Any other thoughts that people have about this paper? We're thinking about submitting it to the Green Journal. So it's an OBGYN journal that kind of just talk about like what we do clinically, like Margie, like what we do in OB Motivate, for example, like all the phone calls, all the like to just today, right? We did so much for our jail patients today. And the fact that any jail can send their patients to VCU and when they're pregnant and get started on buprenorphine. We're the only hospital in our area that does that. So we're obviously going to talk about the clinical context as goes on in, but if anyone has any, before we close, if anyone has any thoughts on just things that we should make sure to bring up in the discussion, we appreciate it.
Thank you for the work. It's so interesting to just listen to how you all put all this together and what you're doing. I think it's awesome. I'm just kind of curious. I know that Andrea, I think it was your part, you did mention that you did some looking at, was there an impact if they had started incarcerated, but then they left incarceration, correct? And I think that number at delivery for continuation was just a little bit lower, maybe, I think. Are you all, is it beyond the scope of this paper, or maybe it could be part of the implications of looking at that? I think Dr. Martin's talked about it many times. It's just such a a struggle with insurance once they get out sometimes. And so although we're there and Dr. Martin is there at the ready to provide patients with care and a prescription, and we get an appointment, if their insurance is still hung up in the, Department of Corrections, and, they can't get it because they can't afford it. We're working on that, but it is a point of contention right now. So just kind of, I think you brought that up, Andrea, in one of your little charts. That little
Yeah, I think
that it started, they stopped, not necessarily in and out, but
mhm.
yeah.
Yeah, and I think for the purpose of this paper, it's beyond the scope, but we have that information. So we have, like, in the 4-week intervals that we've been looking at, whether or not they were incarcerated then, and then when they weren't incarcerated, so we can go back and see exactly when they got out and when they got in, and then tie that with their insurance. But I think that's probably gonna have to be like another study. Yeah.
Right. Yeah. Right. Yeah. And it looks like it didn't matter which jail they were at. I'm assuming. But originally, when we started, I thought, oh well, they see Dr. Martin and Dr. Tyson as in RICO, but it looked like anyone who was incarcerated had a very good, at 100%, buprenorphine stay rate at delivery. So yeah.
And we have recorded like where they were incarcerated too. So if we wanted to like look into that and to see like other characteristics like later on further down the line, we have that too.
Oh wow, great.
And my personal dream is to do this in the Medicaid population because we have incarceration data. So I would love to take that sample. Obviously, it would be only those on Medicaid, but I think that will also help us get a broader picture.
Okay, well, we are out of time on that really exciting note, Hannah. Go and save the world with the Medicaid claims that y'all have. I'm excited to see that data. I know you guys have the prison data right now, not the jail, but I think that's still a huge step forward because a lot of the data that's been published recently has been focused on the prison. So you'll be able to really work off of what other people are starting to do, especially people in North Carolina and in Baltimore. So it's great. So, and then Margie, what you were saying about the jails, actually most of the people, everyone that we included in the study was started on BUP as an inpatient. And as you know, that includes a lot of people, not just in RICO jail. So it's good that even with the jails that are a little harder to coordinate with, like Riverside, et cetera, that we were still able to see pretty good continuation rates. So that was very motivating.
Yeah, that's what I was thinking too. Yeah. Like, wow, okay, they're keeping to it. So that was good. Yeah.
Yeah, a huge testament to a lot of your hard work, Margie, with these gaps in care. It's true though. Okay, well, we're over time, but thank you everyone for coming to our lab meeting.